Okay. Okay. So today we will discuss some embryological stuff related to the cardiovascular system. So so USMLE doesn't ask this embryological structure in this way. So I give you the example. So they give you the example that they give you that in the fetal you are examining a vessel and the partial pressure of that vessel is partial pressure of the oxygen in that vessel is almost 90 millimeter of the mercury. So from the which of the following structure this vessel is derived? Did you identify this vessel in fetal, in fetus? Hello,
Yes, hello.
I'm saying that you are in the fetus, you are you are examining a vessel in which
Okay.
the partial pressure of the oxygen is more than 90 millimeter of mercury. From which embryological structure this vessel is derived?
I'm not sure.
Okay. So in the fetal, I will discuss these things. We will discuss these embryological structure after the fetal circulation. Then it will make some sense to you, right?
Okay.
Okay. So this is a fetal circulation, right?
Yes.
Okay. Okay. Superior vena cava. Right. You are absolutely right. So we will discuss this question again. Superior vena cava. So first we discuss the fetal circulation. So the fetal circulation. Uh, can anybody tell me the placenta? How many vessel in the placenta?
3 vessels.
Three vessels. Right. Placenta has three vessels. Absolutely right. So the placenta has a three vessel. Two vessels are
Veins, one artery.
two vessels are. Talk, are you
Two
sure?
artery, لا, 2 artery and 1 vein.
Two artery, one.
Exactly. So the two arteries, name of the artery,
Umbilical artery and the umbilical vein.
yes, one vein. So can anybody tell me that what is the origin of these three vessels? What is the origin, embryological origin of these vessels? Can anybody tell me origin of this vessel? Because I am making this thing in the USMLE format. How the USMLE asks questions from the students, right? The origin of the
Okay.
umbilical artery and umbilical vein from the which structure? Can anybody tell?
Yes, um the umbilical vein will be from the ligamental teres, hepatis.
Okay. Can anybody? So these umbilical artery and vein drive from the allantoin. Drive from which structure?
For
Allantoin. So allantoin is derived from which structure? No. Allantoin derived from hindgut. Derived from, this is derived from hindgut, right?
Okay.
And hindgut derived from which hindgut is endodermal, mesodermal, or ectodermal? Can anybody tell me? Hindgut is which? Derived from which embryo? So this is derived from endoderm, right? Okay. Does it make some sense to you? Hello, Rock? Rock, does it make some sense
Yeah.
to you?
Yeah, I think maybe some of the details we're not too familiar with. So if you just lecture on it, maybe then, that will
Okay.
share light
So
and see.
the
Yeah.
hindgut, the lining of the hindgut derived from the endoderm. So mainly the GIT is an endodermal origin, right?
Yes.
Okay. Now moving toward the placenta has two umbilical arteries and one umbilical vein. Umbilical vein has oxygenated or deoxygenated blood.
Oxygenated,
Oxygenated,
Oxygenated, and umbilical arteries deoxygenated.
deoxygenated.
yeah.
Deoxygenated blood means partial pressure almost 40 millimeter of mercury or less than 40, and the oxygenated blood means the partial pressure of the oxygen in between 80 to 100, right? Millimeter of
Okay.
mercury. So this umbilical vein gives their blood to the inferior vena cava, right? So the inferior vena cava has partial pressure of oxygen is 80 to 100 millimeter of mercury. Am I right?
Yes,
Because
because
Yes.
it came from highly oxygenated origin.
exactly, exactly. Okay, so this inferior vena cava uh, has a partial pressure of the oxygen 80 to 100 millimeter of mercury. We will discuss the origin of the inferior vena cava as well, because this is again the high yield stuff. So embryological point of view, they give you the description of that structure, and you have to identify this structure first, because it is a multi-layered question. First, you have to identify that structure, and then you will have to identify the origin of that structure, right? Like if you give you the umbilical artery, umbilical vein, like you are observing, examining the placenta, and you're examining the vein, and you have to identify the umbilical vein has a oxygenated blood, right? And it originates from
From the allantois.
exactly. I'm repeating these stuff so many times because this is I am focusing on this session only the high yield stuff, right?
Okay.
Okay, so this umbilical vein that contain deoxygenated blood, it gives their blood to the inferior vena cava through the ductus venosus, and it may give some portion of the blood to the liver. Ultimately, the blood from the liver is also received by inferior vena cava. So this inferior vena cava reached at the right atrium, and from the right atrium the blood is goes to right atrium to the left atrium through which structure,
Foramen ovale.
foramen
Foramen
ovale.
ovale.
Exactly, foramen ovale. So here is the difference. The superior vena cava, this superior vena cava contain oxygenated or deoxygenated blood.
Deoxygenated blood.
Deoxygenated.
Okay, it contains deoxygenated blood, right?
Yes.
So again, the blood from the vena cava comes into the right atrium. From this blood, mainly from right atrium to the left ventricle, or sorry, right atrium to the right ventricle, right? Right atrium, right ventricle, and then pulmonary artery. So superior vena cava contain deoxygenated blood, and that blood from the right atrium comes to the right ventricle, and then from right ventricle to it moves towards pulmonary artery. So this pulmonary artery contains deoxygenated blood, does not goes to the lungs because lungs are not working properly in the fetus because of the high resistance present. So this blood from the pulmonary artery goes toward descending aorta, and this connection that is present in between the descending aorta and pulmonary artery is known as ductus.
Ductus arteriosus.
Okay, so this is again the high yield stuff because we will discuss the patent ductus arteriosus (PDA) in detail, right?
Okay.
Okay, so what happened in the PDA? This connection that is present between pulmonary artery and descending aorta is not closed. It is a patent, right?
Yes.
So can anybody tell me PDA, what kind of shunt present in the PDA? Right to left or left to right?
I think it'll be right to left.
It will depend if it is intrauterine or post delivery. Because
After delivery, I'm
intrauterine,
talking about after the delivery, patent ductus arteriosus.
after delivery from left to right shunt.
Okay, it's a left to right shunt. It's a left to right shunt after the delivery. Why it's a left to right shunt? Because the aorta has high pressure and pulmonary artery has a low pressure. So from the blood move from the high pressure to the low pressure, from the aorta to pulmonary artery. So that's why it's left to right. But if this PD is untreated, so it with the passage of time, it convert into the right to left shunt. Through which process? Through which Eisenmenger syndrome, right? Okay.
Can you repeat that, please?
Sorry?
No, there was some noise in the background, so I was asking if you could repeat that.
Okay, so we are discussing the PDA. So the pulmonary artery, there is a connection between the pulmonary artery, this pulmonary artery, and this descending aorta. This is known as a ductus arteriosus. If this ductus arteriosus after the birth, because there is increased pressure in the left atrium and decreased resistance in the pulmonary vasculature, it will lead to the closure of this ductus arteriosus and also changing in the prostaglandins. Prostaglandin also decrease after the birth. So it will lead to the closure of this ductus arteriosus normally. But if there is any pathology, this ductus arteriosus does not close. This ductus arteriosus does not close. So what happens? It will lead to the pathology known as a PDA, patent ductus arteriosus. So initially after this shunt is left to right because the descending aorta has a high pressure and the pulmonary trunk has a low pressure. So it is a left to right shunt and there is no cyanosis. With the passage of time, if this disease, patent ductus arteriosus, is left untreated, it convert into the right to left shunt through a syndrome, Eisenmenger syndrome. Right? Rock?
Right.
Does it make some sense to you?
Yes.
Okay. So these are again these are like explanation of that thing that I explained, the fetal circulation. So at birth, NSAID. So this is again the high yield stuff, NSAID. So there some congenital heart disease are duct dependent lesion. So survival of the child depend on the patency of the duct. So in this condition, we want to keep this patent ductus arteriosus to open. So we give
we give prostaglandin.
Prostaglandins E.
Yes. So we give the prostaglandin E. So this is a prostaglandin E1, E2 keep the PDA open. If you want to close this PDA, you have to decrease the prostaglandin. And how will you decrease the prostaglandin?
Indomethacin, like prostaglandin antagonist.
Okay. So commonly used drug.
Endomethacin.
NSAIDs.
NSAIDs. So the class of the NSAID, and particularly endomethacin is commonly used for this purpose, right?
Yes.
So the remnant of this ductus arteriosus is known as a ligament arteriosum. Okay, can anybody tell me any other clinical correlation of the ductus arteriosus? Like one is the patent ductus arteriosus. Any narrowing of the other structure?
Wait, you're breaking up. Can you repeat that, please? Any what?
I'm talking about that. One thing that we discussed clinically, ductus arteriosus is the patent ductus arteriosus. One more thing that is related to the patent ductus arteriosus clinically.
Coarctation of aorta?
Differential cyanosis.
Okay, coarctation of aorta, absolutely right. So the coarctation of aorta, so where this ductus arteriosus insert in the aorta, just distally or around the insertion point, there is a narrowing of the aorta. This is known as a coarctation of the aorta. So anybody tell me what are the key finding in the coarctation of aorta?
There is difference between the
The blood pressure in the
upper
upper
limb and
limb.
lower limb circulation.
Okay, coarctation of aorta, one thing more. Anything else?
There is adult one and infantile one.
Okay, I am not going to discuss the type. We will
Yeah,
discuss these
you
types
mean
in pathology.
that
I am discuss about the generally
okay.
general point. Because
There is differential cyanosis, and there is difference in the blood pressure.
okay,
There is intercostal collateral. The collateral circulations make like collateral blood vessel.
what
the
does this terminology
intercostal,
cause? Can you tell me the name of this terminology? Collateral circulation and changes in the rib on the chest X-ray. What we call this changes? Notching of rib. Am I right?
notching, yes. And there is also the murmur, machinery murmur, where it will be heard between the scapula.
Okay. So one more key thing, radiofemoral delay. So the radiofemoral delay. When you heard about the radiofemoral delay, it's most likely the cause of the coarctation of aorta, right? Okay. So I think this is about the fetal circulation. Let's go back toward the embryological origin of some structure. Wait a minute. Okay, so this is the basically, is my screen is visible to everyone?
Yes.
Okay, so now it makes some sense. In question, you examiner asks you that you are examining a vessel that has a partial pressure of the oxygen is 90 millimeter of mercury in fetus, right?
Okay.
From which embryological structure this vessel is derived?
Allantoin.
Sorry? Okay, allantoin will be the right option. Right, if you are talking about the umbilical vessels, like, but if we precisely say that this is not in the option of that question, so I'm pointing toward the inferior vena cava. So this inferior vena cava contain
oxygenated blood.
Oxygenated blood. So this inferior vena cava contain oxygenated blood, and this superior vena cava contain deoxygenated blood. So the partial pressure of the in vena cava is around 40, and the partial pressure in the inferior vena cava is 80 to 100 millimeter of the mercury. So umbilical vein and umbilical artery are derived from the allantoin, right? So if they are not giving the allantoin type of option, so they are asking about these things. So inferior vena cava is derived from the posterior cardinal, subcardinal, and supracardinal veins. So you have to cram these embryonic structure by heart, right? So the multi-layered question, you have to first identify that structure, and then same is again the superior vena cava. They give you the partial pressure, and they ask about the embryological origin of that vessel. Okay, let's move towards atria and ventricle. So the smooth part and trabeculated part. So the smooth part of the atria derived from which structure? Hello, Rock.
Yeah. Yeah, the
Sinus
smooth part is from the bulbous cordis. That gives you the smooth part.
I'm talking about a smooth part of the atrium.
Oh,
Right.
you have this.
Okay, so one of is the right horn of the sinus venosus, and next is the bulbous cordis. So bulbous cordis, bulbous cordis give rise to the ventricle outflow tract. It's not the atria. Okay, so the trabeculated part always derive from the primitive structure. Like if you are talking about the atria, so the primitive atria, right? If you're talking
Yes.
about the trabecular part of the ventricle, it's a primitive ventricle, right?
Yes.
So make some association. The trabeculated part, trabeculated mean appendages, thickening, right?
Yes.
So the trabeculated part derived from primitive structure. Like if you are talking about the ventricle, so it is a primitive ventricle. So if it's the atria, so it's a primitive atria, right? And another thing is the truncus arteriosus. Can anybody tell me is there any clinical significance this truncus arteriosus?
Yes, persistent truncus arteriosus.
Yes, there is a pathology. There is a anomaly that is. Sorry, can you continue, please? Sorry.
There is anomaly with truncus arteriosus. We talked about yesterday. Persistent
Yeah.
truncus arteriosus.
Okay, so
Yeah. So basically, the spiraling. There will be a problem with an abnormality with the spiraling. The septal spiraling, so you won't have the normal layout where the aorta would take off from the left ventricle and the pulmonary artery would take off from the right ventricle. So it's reversed, and that would now end up, of course, with the sinus.
This is a transposition of great.
Okay, so spiraling is basically the transposition of the great artery. What about the truncus arteriosus? It's basically the formation is impaired. The formation of what thing is impaired in truncus arteriosus?
I think that's one. There's no
migration of neural
right?
crest to aorticopulmonary septum.
Okay, so first thing is the migration of the neural crest cell. Then next thing,
to the endocardial
Aorticopulmonary
cushion.
septum.
Aorticopulmonary septum and the endocardial cushion.
Okay, so you are absolutely right. The first thing is the migration of the neural crest cell, right? Then this migration of the neural crest cell lead to the formation of aorticopulmonary septum, right? So if the spiraling is impaired, then it will lead to the transposition of
great vessels or great arteries.
If the formation does not take place, then it will lead to the truncus arteriosus. So this is some sort of the UWorld and NBME question. So that is I'm forcing these things to you. Okay. Can we move to the next page?
Okay.
Yes.
These are all of the some sort of the information. So they some give you the clinical vignette, and you have to identify the structure or pathology. Like, so the most high yielding topic today is a fetal circulation. You have to understand the fetal circulation by heart. Any question regarding fetal circulation?
Yes. So if you can please scroll up to the diagram.
Okay, give me a 1 minute. Give me a 1
Yes.
minute. Wait.
Yes. Yes, that diagram.
Okay.
Okay. So oxygenated blood will be is going through the umbilical vein, and then it continues through the ductus venosus to the right atrium, and from the right atrium it will now go through the foramen ovale, right, and then enter the left atrium down to the left ventricle, and then it goes through the aorta. Is that correct?
Okay. So basically, in the right atrium, there is a mixing of the blood, oxygenated and deoxygenated blood, right?
Yes.
So the in the aorta contain deoxygenated blood, not in the adult circulation, right? So you noted that the color of the aorta as well, right?
Yes.
So can we move to the next?
Okay.
Okay, does it make some sense to you?
Yeah, I was just trying to, to just to grasp the flow, because you see when it comes from the superior vena cava, it's like it's going down to, well, not that it's like, but it is going to the right ventricle, and then it goes through the pulmonary.
Okay, one more thing.
From the superior vena cava, right?
The
That's what you
blood
said
from the
earlier.
vena cava with either is a inferior or superior. It goes into the right atrium, not directly into the ventricle.
Yes, from the right atrium, it goes to the right ventricle, and then it goes through the pulmonary artery, and because of the high pressure, so it won't be able to go to the lungs, but instead it gets transported to the aorta by the ductus arteriosus. Whereas when blood comes through the umbilical vein, through the duct, and then it gets relayed from the ductus venosus to the right atrium also, but it does not go to the right ventricle. Instead, that one will go through the foramen ovale into the left
Okay, I
atrium
will give
down to
you
the
the
left ventricle,
explanation.
right?
So the mainly blood, although some portion of the blood goes to the right ventricle as well, but we are talking about the majority, the predominant things, right? We are not talking about
Okay.
the minor things.
Okay.
Shit. Okay, these are some sort of uh, things that you have to remember. The ductus arteriosus, the postnatal derivative is a ligamentum arteriosum, and ductus venosum. Ductus, what is the function of the ductus venosum? What is the
This
function
is
of?
like passage. This
It's
is like passage
like a
of oxygenated
bypass.
blood. Yes.
Okay, right. Foramen ovale.
Yes, so blood will leave from right
This is
atrium
between
to
the
left
left
atrium.
atrium and right atrium.
Okay, allantoins, median umbilical ligament. Okay, this allantoin has so many clinical correlation. We will discuss these correlation in the reproductive chapter as well. So sometimes there is allantoins give rise to the uricus. This is uricus is basically the part that is a duct that is present between the bladder and umbilicus. Sometimes it's not closed; it remains patent. So there is a dribbling or discharge of urine from the bladder. If this passage is not closed. So there too other pathologies, anomalies are also associated with allantoins. I'm not going. We will discuss these pathology and reproductive. But the key thing, if this is not closed, this urachus, then what happens? There is a discharge of blood from the umbilicus, right? If they if they give you the some child uh, uh, that urine has come out from the umbilicus, so what is the pathology behind this? What is the pathophysiology? What are the structures that are unable to close? So this is the answer.
Urachus is remnant.
Sorry.
When there is urine dribbling from the umbilicus, it means that the urachus is remnant.
No.
There is
It's a
urachus.
patent. It's a patent.
It's
It's a-
patent urachus.
Yes, it's a patent. Okay, so the umbilical artery, it's the medial umbilical artery derivative of the medial umbilical ligament, umbilical vein. So these do not confuse with this thing, right? Umbilical artery and umbilical vein, they are derived from allantoins, and these are the postnatal derivative. Sir, can you repeat about the pressure in the superior vena cava? Was that in embryo? Okay, wait a minute. I will repeat it for you. Okay. Can anybody tell me why is my okay? So what is the question? Superior vena cava. So superior vena cava and inferior vena cava. So superior vena cava has a deoxygenated blood. Inferior vena cava is oxygenated blood. Oxygenated blood means partial pressure is of oxygen. Partial pressure of oxygen is 80 to 100 millimeter of mercury, and deoxygenated blood means the partial pressure of oxygen is almost
19.
40 millimeter of mercury, right? So
Okay.
sometimes they give you the these kind of the partial pressure in the fetus, and they know about the origin of these vessels. Like they give you the vessel in the fetus that is a partial pressure of oxygen. They also confusing about the umbilical vein and arteries. So if they are talking about the umbilical vein and artery, they give you the placenta. So umbilical vein and artery present in the placenta, right?
Yes, sir. Thank you, got it.
Okay. Does it okay? Can we move?
Yes, sir.
Yes.
Wait. We have 2 minutes left. Can we end this session and we will join after 5 minutes?
Okay.
Okay.
You send a new link, right?
So the anatomy of the heart. So this is the most important. The radiology picture is again high yield. This chest X-ray. So the most posterior part of the heart is left atrium.
Left
This is
atrium.
this left atrium, right? And the most interior part of the heart is
Right ventricle.
Right ventricle.
right ventricle. Okay, so they give you some sort of the confusing question on this. They give you the injury or their injury at penetrating injury at left mid clavicle line, penetrating injury that is present at lateral to the left mid clavicle line. Which of the following structure is injured in this patient? Can anybody understand my question?
Yes, sir.
Okay. So penetrating injury that is lateral to the left mid-clavicle line. Which structure is injured?
Right ventricle?
Left ventricle.
No. Right ventricle?
Sorry?
Left
No,
ventricle.
No,
I'm-
no,
right,
it's the right.
right
It should be the
ventricle.
right. ROV, right ventricle.
All of you are wrong. All of you are wrong. I am expecting that.
Lung.
It's a lung. Okay.
The lung.
So
Okay,
the key thing.
yeah, midclavicular.
Okay. The key
Lung,
thing.
yeah.
So left ventricle forms the apex of the heart, and it can reach at fifth intercostal space.
Intercostal space,
Fifth
mid-clavicular line.
intercostal space. At the left fifth intercostal space. At mid-clavicle line. Right? Left mid-clavicle line. But heart structure are medial to the left mid-clavicle line. If they asking about the lateral to the left mid-clavicle line, so it's the most probably it's the lung, right? Did you understand what am I saying?
No, go over it again, please.
Okay, anybody who can understand.
Yes, because you are away from the apex.
Yes.
You mean this, right?
Okay.
So there is no part of the heart will be injured. This is the lung.
Anyone else who can repeat that thing that I explained now? Hello?
Instead, if it's lateral to the mid-clavicular line, then it's most probably the lung.
Yes. So heart is basically, the structure of the heart is basically medial to the left mid-clavicular line. So the medial word, right?
Yes.
Medial word. If it is lateral to the left mid-clavicular line, it's not a heart. Rule out the every structure of the heart. So it is the lung. Lateral. The key thing is lateral or medial. If it is lateral, it is not a heart. Lateral to the left mid-clavicle line. If it is a medial to left, if it is a medial to the left mid-clavicle line, then it will be the structure of the heart, right?
Yeah, yes, we can connect it like lateral L with lung. And so if there is any question about lateral to mid-clavicular line, it will be the lung, L for
Yes.
L.
So this is a confusing thing. So the confusing thing and difficult thing is always asked in the USMLE. So it makes some sense for everyone. Should we move on?
Yes. Okay. So just a quick recap. If you have like this, like a stat, because yes, you're right. I've seen questions like that, and that's why I asked you to explain, because I've seen two questions where they talk about with the lateral to the MCL and then medial. So that's and it could be a little confusing. So what you are saying is when you have like the stab wound lateral to the midclavicular line, then it's the lung that's going to be injured because you are away from the heart completely.
Exactly.
Now,
that I'm saying.
Yes. Now, if it's medial, because again with the same question, they just give organs, and then the other one that was specific with the part. So if it's medial to the midclavicular line, that means the stab wound has a higher probability of injuring the right ventricle, right?
Yes, that is a concept that I am talking
Okay.
about. Okay.
Yes.
So I hope
Okay.
it's clear to you. Any
Yes.
other that didn't understand this concept. So this is an important concept. So I am highlighting this concept for you. Anyone who didn't understand this concept? Hello, am I clearly audible?
Yes, I think it means that we
Yes.
understand. Yeah.
Yes, we are aware.
Okay. So another high heel thing is the left atrium is the most posterior part. So this radiology picture shows that the left atrium is the most posterior part. So anything like mitral stenosis, if the mitral stenosis means mitral valve is present between left ventricle and left atrium
Left atrium.
Here is a mitral valve. So if there is a stenosis, of the mitral valve, then it will lead to the enlargement of this left atrium, right?
Yes.
So left atrium enlargement compress the esophagus because it is the most posterior part of the heart, left atrium. So if it is compressed the esophagus, it will lead to the dysphagia. And if it compress the left recurrent laryngeal nerve, it will lead to the Ortner syndrome. One more thing. So anything that dilate the left atrium, it will lead what kind of the cardiac cardiac problem? That we
Atrial fib.
Can
atrial
you repeat the question?
Fib.
atrial fibrillation, right? Atrial fibrillation. So anything that, what is the origin of the atrial fibrillation? Most common region.
It's the pulmonary ostia, something like near.
It's the pulmonary vein.
Pulmonary vein.
Right?
Yes.
So anything that enlarge the left atrium will cause atrial fibrillation or increase the risk of the atrial fibrillation. Why? Because the most common region of the atrial fibrillation is pulmonary vein, and pulmonary vein in and in the left atrium. Does it make some sense to you?
Yes.
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 So this is again a high yield concept that is repeated throughout your step 1 journey, right?
Yes.
Okay, can anybody read this heart anatomy from this left atrium to this cardiac surface? Rock, can you read it for me?
What okay, I'm not understanding your question. When you say to read it to the cardiac surface, I don't understand the
Sorry,
question.
I am reading. Okay. So the left atrium is the most posterior part of the heart.
Yes.
The left atrium enlargement in mitral stenosis can lead dysphagia and Ortner syndrome. Okay. Right
Yes.
ventricle is the most interior part of the heart and the most commonly injured in a trauma. Most commonly injured in trauma if it is medial to the left midclavicle line, right?
Yes, right ventricle.
Okay, so left ventricle is about 2/3 and right ventricle is about 1/3 of the inferior cardiac surface. The inferior surface of the heart is 2/3 by left ventricle and 1/3 of the inferior, 1/3 by right ventricle.
Right
Okay.
ventricle.
Okay. Okay. So the pericardium. Okay. So the pericardium. So this picture. So it consists of the 3 layers. Fibrous pericardium, the outer layer. Fibrous pericardium, then parietal pericardium, and then epicardium. Right? So pericardial space is present in between. Pericardial space is present in with epicardium and parietal pericardium. The another name of the epicardium is the visceral pericardium. Okay. So which artery is most commonly occluded in MI?
Epicardium, visceral pericardium, because it is
No,
LAD.
you said
Left.
which
LAD.
yeah,
LADA.
LAD, yes.
LADA, left anterior descending. Okay. Sometimes they give some sort of the MI clinical vignette, MI scenario, myocardial infarction scenario. Or they try to ask you where this occluded vessel is located. So the coronary vessel is located under the or below the epicardium or visceral
Pericardium.
pericardium, right? So this is again a high yield stuff. So the coronary vessel are present below the epicardium, visceral pericardium. So the pericardium innervation is phrenic nerve. Pericardium innervation is
Phrenic nerve.
The phrenic nerve.
Different.
okay. So phrenic nerve, so rapid pain to the neck, arm, or both shoulder, often left-sided. Okay, should we move to the next?
Yes.
Okay, coronary blood supply. Okay, so lot of question from the coronary blood supply. So they ask the coronary blood supply by giving the ECGs, right?
Yes.
USMLE give this kind of the question, giving you the ECGs, ST segment elevation, right? Interior MI, posterior MI, lateral wall MI. I I uh, I expect that you heard this terminology so many times. Interior wall MI, lateral inferior wall MI, right?
Yes.
So what is a lead? What is the ECG lead? Can anybody tell me what is
What?
the lead of ECG?
Electrode.
What?
No, the electrode is a different thing. Lead is a different thing. Like
Yeah.
2, 3 AVF, right?
Yes.
So these are lead.
Inferior.
Which lead? Inferior lead. So the leads are basically the picture of the heart. So 2, 3 AVF magnify the inferior picture of the heart, right?
Yes.
So if you found any elevation in 2, 3 AVF, so it is a which MI? Inferior wall MI, right?
Yes.
Okay. So in inferior wall MI, which vessel is included?
Right coronary.
The right coronary.
Right
Yeah.
coronary. So they asking you, they started the question. So they asking this anatomy by giving you the myocardial infarction scenario, giving the ECG to find or mention that the elevation in that lead, or they give you the ECG that you find the elevation in 2, 3 AVF. First, you have to find the elevation in the ECG 2, 3 AVF. So the multi-layered question, give you the MI, give you the ECG, you have to identify the things in the ECG, right? 2, 3 AVF, and that if there is elevation in 2, 3 AVF, so which vessel is included? Which vessel is included?
Can you repeat this question again?
Okay, I see that in the clinical vignette, in the USMLE, they give you the clinical vignette of the myocardial infarction, and they give you the ECG. On ECG, you found that there elevation in the 2, 3 AVF, right?
Yes.
Okay. So now the next task, you have to identify the which vessel is a culprit of this pathology. Which
Yes.
vessel
So
is
that's why we say the RCA.
right
Right
coronary
coronary
artery,
artery.
right coronary
right
artery.
coronary artery.
Okay.
Inferior
So
MI.
this
Posterior descending.
no, right coronary artery. Okay, I am not confusing some more precise concept that I am not going to discuss here because it's so difficult. So in right coronary artery, more than 50% of time, in inferior wall MI, more than 50% of time, this artery is occluded, right coronary artery, right?
Right.
So the inferior wall MI that involves the right coronary artery. So if right coronary artery involved, and this lead, if this lead to the right ventricle infarct, which infarct?
Right ventricle infarct.
So what happened to the preload of the left ventricle and what happened to the preload of the right ventricle?
The preload of right ventricle is severely decreased because the right myocardial infarction associated with severe hemodynamically instability and severe hypotension. So the preload will be decreased, and also the preload of left ventricle.
No, I'm talking about the preload of the right side and preload of the left side.
Preload will be
increased because it will be, oh yes,
On which side is increased?
hypokinetic.
On which side is increased?
Right side. In right
Okay,
side.
what about the left side? What about the left side?
Because the
Decreased.
right ventricle would not be able to pump the blood into the lungs, so I guess there will be decrease of preload on the left
Okay.
side.
Okay, you are right. It is a difficult concept that I am explaining. So if right ventricle infarct takes, if the preload is increased on right side, right? But preload is left side is decreased. The preload, what is a preload? Preload is a left ventricle and diastolic volume. We will discuss this thing in the next page. So don't worry about this. But so I am going to the format of the USMLE that they ask the question in that way, right? So the preload on the right side is increased and preload on left side will decrease. Okay, so this is a different, the most different MI. So usually we restrict the fluid in the MI, right? We restrict the decrease the fluid in MI.
Yes.
Why we decrease the fluid in MI? To decrease preload.
To decrease preload and the work of heart.
Okay, so decrease preload and decrease work of heart. Decrease oxygen demand. Decrease work of heart. But in this case, so we give nitrate. So nitrate decrease preload, right?
Yes.
Nitrates main effect are venodilator.
Yes, because
So the
venodilation.
Venodilation. So the preload is decreased by nitrate. But in this case, we avoid nitrate. Right ventricle infarct, we avoid nitrate. The patient present with the severe hypotension. And in this case, we give fluid. We give IV fluid, right?
Yes.
Yes.
Because although the preload of the right side is increased, but if we didn't give the fluid to the patient, the preload of the right side will also decrease, and the left side preload will severely decrease, and it's unable to maintain the stroke volume and the cardiac output, right? So this is a different thing. So we avoid nitrates in the right ventricle infarct, but we give the nitrate in other MIs, right? This is a
Yes.
higher.
Also, we avoid beta blocker.
Okay, this is again beta blocker. So the right coronary artery also supply the AV node and HC node. So the patient may present with bradycardia,
Block.
right? Bradycardia or heart block, right? So we avoid beta blocker as well. One more difficult thing related to the right ventricle infarct.
Can you please repeat why we are not giving nitrates in right-sided heart failure?
Sorry, I cannot hear. What are you saying? Can you repeat your question, please?
Can you please repeat why we are not giving nitrates in right-sided heart failure?
Okay, why we give if the patient is suffer from the right ventricle infarct, although we know that the preload is increased in the right side and preload is decreased in the left side, right? So if you give the nitrate to the patient, you decrease the preload of the right side as well. And if the right side preload is further decreases, then the preload of the left side will also decrease. and the patient is unable to maintain the stroke volume and the cardiac output. Right?
Okay, false. Right.
But in other types of the MI, we give the nitrates to decrease the preload. But we avoid. We also avoid the beta blocker if the patient present with the bradycardia. And you noted that the patient is suffered from right ventricle infarct on the ECG. Right? So if the patient is you find the symptomatic bradycardia, what will be the treatment of that patient? How will you
Symptomatic bradycardia.
Atropine.
atropine? Atropine is the first line of the drug if the patient is present with the symptomatic bradycardia, right?
Okay.
After the atropine, you give the IV fluid that patient. So this is the right ventricle infarct. So it is some sort of a unique MI. So that's why I'm explaining it in very detail, right? So the way we already discussed LADA, left anterior descending artery, it is a most commonly occluded artery. This artery is most commonly occluded in MI, right? So it supplied the interior 2/3 of the interventricular septum, interior lateral papillary muscle, interior surface of the left ventricle, and it most commonly occluded, right? So you have to remember these structures that are supplied by the left interior descending artery. So there is another concept that present in this, the dominance. So it's a simple. So it's basically the which side give rise to the posterior descending artery. If it is come from the right coronary artery, then the coronary circulation is right dominant. If it is come from the left side, so it is left dominant coronary circulation. And if it arises from the both sides, then it is co-dominant circulation. Okay. So one another high yield stuff that is present in this slide. So the coronary blood flow. They give you the scenario about some sort of, and they are asking about in which phase of the cardiac cycle left ventricle receive blood, in which phase of the cardiac cycle?
Diastole.
Early diastole.
Diastole, yes.
Diastole.
Because it is a unique thing, although the other thing, other organ or other structure in the body receive oxygenated blood during systole. But is the left ventricle is a unique thing that receive blood in the early diastole. During systole, what happened? The coronary artery that are present on the left ventricle are compressed due to high pressure, right? So that's why left ventricle receive blood during early diastole. Okay, one more thing. So what is the coronary sinus? Can anybody tell me what is the coronary sinus?
It is
In
like
the right
venous drainage.
where the coronary veins drain.
Okay, so it's drain into the right atrium, right?
Yes.
Venous drainage of the right atrium.
So can you tell me the causes of the coronary sinus dilation?
Anything causing right atrial dilatations.
Yes.
Anything that dilate the right atrium. So what are the causes of the right atrium dilation?
Tricuspid stenosis. Oh, yes.
Sorry?
Tricuspid stenosis or anything causing right ventricular failure or dilatations like pulmonary hypertension or pulmonary stenosis, tricuspid stenosis.
Okay. What about ASD? Does ASD leads to the dilation of the right atrium?
ASD? No. Maybe in the latest. No, maybe in the latest stage, if it is become as a Menger syndrome, because it is Oh, yes, yes, yes. This is right. Left to right shunt, this is cause right atrial dilatation. Yes, you are right.
Okay. So I think this is some sort of the high yield stuff. I'm not explaining the everything. So basically, I done with step one. So I thought that things are important for you. I try my level best to explain that thing. Okay.
Yeah, so maybe Doc, some of the stuff that needs a brush up over the fundamentals, maybe if you approach it that way, it will make a little more sense just to lay that platform.
Okay. I encourage you to ask the question. If somebody didn't understand, I try to repeat that thing, right?
Okay.
Okay. Okay. So this is a cardiac output. So can anybody tell me the formula of the cardiac output? What is the formula of the cardiac output?
Yeah, it's a heart rate times
Gross
stroke
stroke
volume.
volume in the stroke volume multiply in the heart rate.
Okay. So it is
Stroke
a
volume into heart rate.
stroke volume into heart rate. So this is the formula of the cardiac output. Stroke volume into the heart rate. So what is a stroke volume? What is the definition of the stroke volume?
And diastolic volume minus end
And diastolic minus.
and
Systolic.
systolic.
Okay, so you are right. So it is basically the volume that is ejected from the ventricle. So it is a volume of the blood that is ejected from the ventricle, right?
Yes.
Yes.
Yes. So you have to remember SV cap. SV cap. SV cap is basically stroke volume affected by contractility. If contractility is increased, stroke volume is increased. So it is affected by the afterload. What is afterload? Afterload is basically determined by the mean arterial pressure, right? If the mean arterial pressure is increased, so stroke volume will be decreased, right?
Yeah.
And if the preload is increased, so stroke volume is increased. We will discuss this correlation in the Frank-Starling law in the next slide, right? So what about the failing heart has decreased stroke volume, right?
Yes.
So the contractility. So first factor that
I
determines.
I want to ask a question because I always confused between stroke volume and cardiac output. What is the difference between them?
Okay, so stroke volume is basically the determinant of the cardiac output, right?
Yes.
While the cardiac output is a broader terminology, although we assess the same thing, cardiac function, right?
You mean the are but in different
Yeah.
terminology?
Yeah. There's a correlation because the stroke volume will determine the cardiac output. So if stroke volume is impaired, like if you have, say, for example, dilated cardiomyopathy, there's problem with contraction, and there's also a problem with stroke volume. So, I mean, there's a correlation there, but yeah, it can be a confusing concept. I agree with her. So you just have to picture to know that contractility is the ability of the heart to contract.
Doc, you are confusing things. You are think of the concept that is the ejection fraction. So ejection
No,
fraction is another thing that we will discuss. On the basis of the
no,
ejection fraction, we will divide the heart failure into the systolic and diastolic heart failure, right?
no, no. She's asking She's saying that she has a confusion all the time with knowing the difference between stroke volume and contractility. That's what she's saying. So what I was saying was, yes, I agree. It can be a little bit confusing. So the way I try to remember is that contractility, okay, the heart needs to contract in order to pump blood out, right, to the body. And the stroke volume, basically it includes the contractility. So how much the ventricle receive, like how much blood the left ventricle receive, and the heart ability to to pump out that blood that it has received.
Okay,
So that's
Doc,
what I was saying.
give me a time. I think she asked a question about the stroke volume and the cardiac output, right? Doc, can you
Yes,
repeat your
yes,
question?
yes,
Okay, the stroke
yes, yes.
volume,
I
stroke
always
volume.
confused
Okay,
between stroke
give me,
volume and
because we
cardiac
have a
output.
shortage of time. I thought we complete the cardiac output today, but we didn't complete it. Okay, so I will conclude this session. So the cardiac output and stroke volume. The stroke volume is basically the determinant of the cardiac output. But when you discuss about the cardiac output is basically the blood that is pumped by heart in 1 minute, in per minute. While the stroke volume is basically the blood that is ejected by during one contraction of the heart, right? Hello, Doc, can you hear me?
Yes, yes,
Right.
Yes, I can hear you. We can
yes,
hear you.
So the stroke volume is basically the blood that is ejected by the ventricle by one single contraction, and the cardiac output is the blood that is by pumped by per minute, right?
yes.
Okay.
Yes.
So next, the determinant of the cardiac output. So the cardiac output is basically the stroke volume into the heart rate. Now we're going to discuss about the stroke volume. The stroke volume is basically depend on the contractility. So the contractility is basically the inotropy. So the catecholamine, epinephrine, and norepinephrine, right? So
Yes.
epinephrine and norepinephrine. So how they increase the contractility? Through the beta 1 receptor. So the beta 1 receptor present on the heart, right? So what does beta 1 receptor do? The beta 1 receptor coupled with GS protein, right?
Yes.
Beta
Yes,
1 receptor.
yes.
So the receptor again high yield stuff. So that these are coupled with GS protein. So what does GS protein do? They
Stimulatory, like
are
cyclic
stimulatory
AMP.
protein. So they
Mm.
convert ATP to
Cyclic AMP.
cyclic AMP. So this cyclic AMP lead to stimulate the protein kinase,
Stimulatory
protein
protein kinase
kinase,
A.
protein
A.
kinase. This is high yield, and the receptor like beta 1, beta 2, and M2 receptor again the high yield. We will discuss in the separate session. So this protein kinase. So the kinase means phosphorylation, right? They phosphorylate the many proteins. And one important is phospholamban. So they phosphorylate the phospholamban. What is the function of the phospholamban? Can anybody tell? The phospholamban basically inhibit the calcium ATPase that
It,
present on the sarcoplasmic reticulum, right?
Yes.
So if you phosphorylate, so this protein kinase A will also lead to the calcium influx. So the calcium influx is important for contractility.
Contractility.
Okay. So another thing, digoxin. Digoxin is again a high yield stuff. So digoxin is a class of the cardiac glycoside. Cardiac glycoside. So the cardiac outside, they basically block the sodium potassium pump. Sodium potassium pump is the example of the which transport?
Active.
Active transport.
Primary or secondary?
Primary.
It's a primary active transport, right? So what does do? If this is a cell, this is the inside of cell, this is outside of the cell. What does it do? Sodium potassium pump.
Sodium enters the cell and potassium
Exit 3 sodium out of the cell and enter 2 potassium inside the cell.
Okay, 2 potassium inside and 3 sodium. The 3 sodium outside, right? So they affect another transport mechanism, that is sodium calcium exchanger. It is an example of which transport? Sodium calcium exchanger.
Secondary.
Secondary active transport. And secondary active transport dependent on primary active transport.
Primary.
If you block this primary active transport, what will happen? This secondary active transport will impair, right? So this secondary active transport, what does it